Good afternoon, everyone. Welcome to our session, Familial Pulmonary Fibrosis and Genetic Counseling. I am Janelle Speller, Vice President of the PFF Registry. I would like to introduce you to our speaker, Janet Talbert, Board Certified Genetic Counselor and Associate in Pediatrics of the Division of Medical Genetics and Genomics at Vanderbilt University in Nashville, Tennessee. Ms. Talbert earned her Master of Science in Biophysics and Genetics at the University of Colorado Medical Campus. She became Diplomat of the American Board of Genetic Counselors in 2009. She also is a member of the National Society of Genetic Counselors and the American Board of Genetic Counselors. Ms. Talbert worked in the Interstitial Lung Disease Program at National Jewish Health from 2003 to 2020 in roles that included oversight of a national familial pulmonary fibrosis genetic study, providing genetic counseling services for the institution at large and to patients and families with FPF. She also served as genetic services manager and a genetic advisor to the institution. Ms. Talbert has been working in genetic research and genetic counseling of familial pulmonary fibrosis for over 18 years. And with that, I will hand that over to Ms. Talbert. Thank you.
Hello, my name is Janet Talbert. I'm a genetic counselor in the Division of Medical Genetics and Genomics at Vanderbilt University. And today I'll be talking about familial pulmonary fibrosis and genetic counseling. My goals are to have an overview of familial pulmonary fibrosis, how to access genetic counseling, and go over some of the recommendations for genetic testing and counseling in pulmonary fibrosis. So a little bit about myself. I have been working in pulmonary fibrosis for 17 years, going on 18 years now. Started as a familial pulmonary fibrosis study coordinator where we were enrolling families with this diagnosis in their family, trying to find genes, and those studies are ongoing. It inspired me to become a genetic counselor since I couldn't always answer everyone's questions about risk and genetics. And over those years, I was with National Jewish Health. I had many roles in genetic counseling of patients with pulmonary fibrosis in the clinic, also directing a telephone line that was national where providers, physicians, family members, or patients could call us and ask questions over the phone. And because pulmonary fibrosis genetics are so complicated, I decided to step out of my comfort zone and learn a little more about hereditary cancer, as I think the two of them overlap as far as genetics, maybe not so much the disease process, but the genetics are very similar. And since inherited forms of cancer and cancer research is so far along, much further along than pulmonary fibrosis, I felt like I should learn more about that field so I could bring it back to this diagnosis. And in the interim, I also worked for a genetic counseling telehealth company where genetic counseling and testing can be performed remotely. I worked in cancer again, oncology, inherited retinal disorders, neurological like Alzheimer's disease, and I tried to set up a pulmonary fibrosis program, but then as we all know, COVID hit, so it kind of derailed my plans there. And I've been fortunate enough to join the team at Vanderbilt, and it's kind of a good mix. I'm there for a special project helping physicians understand genetic test results because they're not for the faint of heart. And along with that, Vanderbilt has had a very powerful great researcher experts in the field in pulmonary fibrosis. And I'm allowed, again, to participate in that research and with the patients. So I'm enjoying my role there. My only disclosures is that I serve two roles for the Pulmonary Fibrosis Foundation. I sit on their medical advisory board, and I'm also a healthcare ambassador. Prior to COVID, I would travel around and give these talks to support groups or to grand rounds and physicians or symposiums. And since COVID, I am here on Zoom, which is fine because I can reach more people this way. So today I just want to orient to what we're going to be talking about the genetics for familial pulmonary fibrosis. First, you have to understand just a little bit about the background of interstitial lung disease, which really is a very big umbrella term for where the disease is occurring in the interstitium of the lung, where the air sacs meet the capillaries and where we exchange oxygen and carbon dioxide. And that's where the scarring, pulmonary fibrosis, it just means lung scarring. That's where the scarring is taking place, and it's preventing that exchange of gases. So with 200 disorders having pulmonary fibrosis as a side effect, we definitely have different camps of diseases. We have what we call known causes, such as autoimmune disease, occupational exposures, even some medications like chemotherapy can scar the lung. Then we have other groups where they're diseases unto themselves and they have lung scarring as a side effect. All of these may have their own treatments or approaches or outcomes and prognoses. But where the genetic research and a lot of our focus today is going to be spent on this group, this idiopathic interstitial pneumonia, which we call idiopathic pulmonary fibrosis. And even that can be broken down further into subtypes, with IPF or idiopathic pulmonary fibrosis being the most common. The difference is that even without a known cause, these usually progress. So we can't stop it because we don't know what's causing it. We can't treat it because we don't know how. And so that's why there's been a lot of genetic research in this area. So whenever you have a disease that you don't know what's causing it, and especially if it's running in families, you tend to think about genes. So finding genes in IPF or idiopathic pulmonary fibrosis would help us define what's causing it. And it might even help us understand why it's occurring. How can we stop it? We could maybe even develop therapeutics, clinical, treatments designed to, if we know how the disease is occurring and how it's building in the lung. It can also aid in diagnosis. Over the years, I've heard one constant, and that's been that the patient has been misdiagnosed for many years until they come to a specialist or someone knowledgeable in IPF. So getting a sooner diagnosis would be helpful in improving the outcome for the patient. And with a genetic test, we could also possibly identify other people who are at risk, who haven't developed pulmonary fibrosis, or maybe in families, unaffected family members who are at a high risk of developing it due to the family history. If we know a gene mutation, we can actually test those people for it. I say that the genetics of pulmonary fibrosis kind of mimic those of what we've learned in cancer. This is about as far as we get right now. Cancer has gone further. They can actually use genetics to treat the patient, to design therapies for the patient, chemotherapies, treatments, and really personalize that experience. So I don't think we're far behind in pulmonary fibrosis, but we're getting there. When I think about especially idiopathic pulmonary fibrosis from the standpoint of how it impacts the differences between familial and sporadic. Sporadic means usually that there's only one case in the family, it's random. So up to 80% of the time, a patient does not have a family history. Up to 20% of the time, there is a familial component, at least two people in the family. A patient may say, yeah, my mother had this as well. And out of that 20%, we can find a gene mutation about 25% of the time, which equals out to about 5%. And we call that hereditary, where we know we can find a gene mutation. I mentioned cancer. If I were to put up a pie chart of cancer, it would look very similar. Only a small proportion is inherited. A little bit larger is familial, and the rest is sporadic. And that's why I say that we can learn from the cancer world as well. This is what we call a pedigree in genetics. We like to draw pictures. So it really gives us a quick snapshot. So I'm just going to point out a few things here. A pedigree usually has at least 3 generations. Squares are males, circles are females. We typically color in the people or the person with the diagnosis that we're currently talking about, and we put an arrow to that person, and that's usually the patient sitting right in front of us. So you can see from this picture, this is the only person with IPF in the family. Now you contrast that with some of the familial pulmonary fibrosis pedigrees, and right away you can see there's a problem. This disease is much more prevalent in these families than the sporadic case, obviously. And what we see here, sometimes we see families where just one generation happens to have the diagnosis, or maybe we see multiple generations, like here. Sometimes we see males and females equally affected. I know pulmonary fibrosis in general tends to affect, is skewed more towards male development, but in the families, we think men and women are equally affected. One concept here I'm going to talk about, especially with dominant disorders that we're finding genes for later onset disorders, is this concept of what we call reduced penetrance. A lot of people might say skipping generations, if you've ever heard that. So what I would say to that is genes don't skip generations. They're either passed down or they're not. However, the disease, whether it shows up, is what skips a generation. So in this case, this grandfather had the diagnosis. It was 50-50 being dominantly inherited to be passed down. And in this case, another generation was affected without this person being affected. And so what that could mean is that maybe they didn't have some environmental trigger, or maybe they didn't live to be the age where pulmonary fibrosis would have shown up. But sometimes it looks like it skips a generation, but a gene mutation can still be passed down. And in later onset genetic disorders, we don't see what we call full penetrance, fully manifestation of the disease. We see incomplete or reduced. Sorry about that. So this is another schematic to explain that concept, autosomal dominant disease with incomplete penetrance. Autosomal just means men and women both can carry that gene. And in this drawing, you can see we have an affected father. Let's say he has pulmonary fibrosis. And let's say he's like 75. He has one copy of a normal gene and one copy with an abnormal gene. This is the pulmonary fibrosis gene in this family. The mother has 2 normal copies. Every time they went to have a child, she had to give one copy, he had to give the other. And it was a coin toss, 50-50, whether that abnormal copy or the normal copy got passed down. So in this schematic, this son got the abnormal copy, but he did not develop the diagnosis. However, this daughter did get the abnormal copy and she did get diagnosed, but these 2 didn't carry either one. That is what autosomal dominant with incomplete penetrance has. And we see that in cancer as well. And let's just take a step back and just talk about genes and DNA, just so I can move forward with the rest of my information. Our DNA, our complete genome, is in every cell of our body. We started out as one cell. The physical structures that carry our DNA are called chromosomes, and that's what are in the sperm and the egg when they come together. And chromosomes are really just tightly wound coils of DNA. And our DNA is made up of 4 letters. And they have a certain pairing. T always pairs with A, and C always pairs with G. When we talk about genetic disorders, they can be anywhere on the spectrum. They can be where a whole chromosome is either missing or doubled, like in Down syndrome. There's 3 copies of the chromosome, 21. You can have whole arms of chromosomes missing, which means a whole lot of DNA missing. You can have it duplicated. But really, in later onset disorders, what we usually see are just tiny little typos along the genes in the letters. Because usually when you have these larger structural mishaps, you usually see that in childhood, or it's not compatible with life at all. So when we get to be older, and we may carry some of these small, what we call mutations or variants, and they're kind of like typos. I like to think of them like typos in a book, and your genome is a library, and you have 2 copies of every book, 2 copies of every gene, one from your mother, one from your father. And we all have typos in our DNA. That's what makes us different from each other and not clones of each other. So these typos can sometimes be harmless. Very rarely they are harmful. And sometimes we just have typos and we're not really sure if they're good or bad, because we really haven't gotten down to that level. We think we know what's normal, but since every human hasn't been tested, whether they've lived or aren't born yet, because of that genetic variation, sometimes we get back an ambiguous result with a change that doesn't really fit all the rules to be harmful, but doesn't fit all the rules to be harmless either. And so it's somewhere in the middle, and we can't really determine if that's harmful or not. So when we talk about variants, I'm really talking about little changes in each of the letters. And so rare variants are ones that are rare. They're not in the majority of the population, or else everybody would be, in this case, walking around with pulmonary fibrosis. They usually follow those patterns of dominant inheritance, recessive, or X-linked, maybe what some people have learned through school. And they're usually associated with classic genetic syndromes like cystic fibrosis, Marfan syndrome, even those inherited forms of cancer like the BRCA gene. Rare variants seem to carry a stronger effect in the risk of disease onset. Sometimes it's 100%. If you carry a mutation or a variant in a gene, you are going to get that disease. But as I said, pulmonary fibrosis and other later onset disorders are following that dominant inheritance pattern, but with reduced penetrance. So it doesn't always mean you will get it, but you're at a higher risk. And also a point I want to make is these variants or typos can happen anywhere in that book, and it might be private to each family. So by studying families and finding genes and gene mutations or variations, just help us understand how complicated this can be for each family. Now, something new on the block are these common variants. And common variants are ones that are very common in the population. Maybe 10% or 50% of the population carry the same genetic variant, or we say mutation, but it's got a smaller effect. It's more of a risk factor than a direct cause. It can also be inherited. It can also maybe be multigenic. Maybe a lot of little mistakes in these genes add up to bring on the disease. And a lot of these companies like 23andMe, the Ancestry test, maybe a pharmacogenomic, trying to see what medication works for you, they're using these point mutations or point variants because they're the same. They're like a hotspot in that gene. They're not all along the gene, but they're always in the same place. So it's easy to target and see if you carry one of those or not. These have been shown in cancer, heart disease, diabetes, pulmonary fibrosis. So the common variants are good for therapeutic targets. So stay tuned for that. So this is our slide of all the different genes that we've discovered so far, especially in the families. And I don't apologize for the complexity because this is very complicated genetics as well as for a complicated disease. But I'll walk you through it. On the y-axis here, we have effect, meaning how likely you are to develop pulmonary fibrosis if you have a variant in one of these genes. The rare variants all cluster here. They carry a lot more weight. They're more penetrant, they're more private, they're rare. These are all the different genes that we've discovered so far in the families. The genes are described like an acronym. So this one is TERT, TERK, PARN, for instance. Each one of these stand for something, basically what the gene does. But in all, we've only found about 10 or 12 genes that run in families that we can blame for the pulmonary fibrosis in that. And it's only 25% of those families. When you go down on the x-axis, you start to get a smaller effect size, but more common. And these are genes as well, and they may too be playing a role in the development, but they're also in the general population, and people in the general population with these same mutations don't develop pulmonary fibrosis, even when they carry these. So when I talk about the rare genes with the rare variants, they're really in three camps. First of all, I just want to point out this section here. They're really rare, they're syndromic, they might even show up in childhood. We usually catch these people really young. The people walking in with adult onset pulmonary fibrosis that runs in families are usually in one of these two camps. And this one is the bulkiest here. The telomerase genes, telomerase is a protein made by a gene, or multiple genes, that we keep finding mutations in different genes in this pathway that tend to put a high risk for pulmonary fibrosis in these families. So 20 to 30%, roughly 25%, have a mutation in one of these telomerase genes. We can also see, sometimes we just see pulmonary fibrosis in these families, but we can also see things like liver cirrhosis of unknown cause, bone marrow failures. Premature graying is probably my least favorite example, because there's so many other ways to get prematurely gray, including stress. But it's just one of those things that's easily to see. But it doesn't mean if someone has premature graying that they have a pulmonary fibrosis gene. Not at all. These genes, usually if you just have one copy of a mutation out of the two copies of your gene, you're more prone to pulmonary fibrosis. However, if by chance you have two copies, it's usually showing up as a more severe disease in childhood or infancy period. And again, they exhibit dominant with reduced penetrance. The surfactant protein genes, surfactant is a very important protein in the lung that help the alveoli maintain their structure and their function. Usually we see childhood onset or earlier age, like under 50, but we can see, especially with one of these genes, maybe a grandfather with IPF and maybe a child with interstitial lung disease. However, again, it only makes up about 3% of our families. So at the end of the day, what I'm usually counseling about is that this is a very complicated disorder that takes a while to diagnose. It's a diagnosis of exclusion. Then the genetics are very complicated as well. And we call it multifactorial genetic disease. So a lot of times we're all born with these genetic factors. We're actually all carrying around 5 to 10 gene mutations that could kill us. However, it might take environmental factors or triggers. And as you live your life and get older and older, sometimes that cup runneth over and the marbles start to spill out from the environmental factors, and then we have disease. So we say that this is more of a gene and environment disease. And I would say the same for cancer. Sorry, I keep bringing up cancer, but it's so much like it. So this is why there needs to be a role for genetic counseling in the familial forms of pulmonary fibrosis. We already have multiple genes. Genetic testing, we have 20,000 genes. So someone knowledgeable needs to be able to know which genes to order, what test to order. We can order multiple genes at once. It's called panel testing. How much does that cost? Is insurance going to cover it? Luckily, costs are coming down. How is this going to impact the patient in the clinic? Is it going to change anything about their clinical care or treatment or prognosis? Are there any clinical trials looking at genes in pulmonary fibrosis that they can be part of? If there's a mutation found, what does that mean for their siblings or their children? Are they going to have insurance at the end of the day? Is this going to be kept confidential? What other services can we have for patients with a genetic form of pulmonary fibrosis? And all that leads into the psychosocial impact. So the counseling part of my title is not necessarily so much as delving deep into feelings or childhood experiences, but it's more recognizing that there's baggage that comes with genetic testing. Most people have never encountered genetic testing or a genetic counselor. They know something's in their family. They know they have risk. Sometimes people overestimate their risk. They may not understand that just because their father had it, they're going to get it. So they might come to the session with preconceived notions, preconceived estimates of their risk. Things like, are they going to develop it? Are they going to pass it down? Sometimes they don't want to know if they carry a gene mutation or not. And what's special about the familial form of pulmonary fibrosis, I know when I started working in pulmonary fibrosis, I had never heard of it. But these families who've watched maybe multiple family members go through the process, they're already aware of the diagnosis and how powerful it can be. So they could be scared. I have survivor's guilt here because it's an interesting concept in genetics, where some people who end up without a gene mutation or don't get a disease in a family often feel guilty because they escaped it. And all of this leads to the fact that all of these feelings really translate into these patients and their family members really wanting to help the next generation or other people down the road. And so that's what's been the most rewarding, is working with these patients and families in the research, because they have such a strong desire to help others. So going back to sporadic IPF, since it is the majority, we don't really recommend genetic testing, because really only about maybe 1 to 5% of the time we're going to find a gene mutation in the sporadic forms, as opposed to 25 to 30% in the familial. But they may still have questions and concerns, especially with those common variants. Maybe the common variants are playing more of a role in the sporadic cases. So sometimes they have questions for genetic testing, but overall, they participate in research, and we don't highly recommend genetic testing at this point. In the familial forms, however, they do have a stronger sense of this running in their family, having an inherited component or genetic component more strongly. They may have more concerns for their personal risk to develop it if they have never had the diagnosis, or maybe if they have the diagnosis, they're worried about their children or grandchildren, and maybe their siblings as well. Some families I've worked with have even made life choices or even reproductive decisions based on this running in their family. And that's where genetic testing could be used as a tool for other family members to help them make these decisions with more of an informed choice. And they benefit us by participating in research as well and finding more genes. So genetic testing, one of our mottos in genetic counseling is we want to get the right test for the right patient. If there's 20,000 genes out there as a human, which ones do we really need to focus on for pulmonary fibrosis? What section of the library do we need to look in? We know that there are a few genes in the grand scheme of things. It's not one gene, but it's about 10 to 12 that we can test for. And a lot of laboratories now offer what we call panel testing, where they can look at all the genes that are currently known to be associated with pulmonary fibrosis at the same time. So usually it's a little more costly for the first family member, usually someone with the diagnosis. I always say, if you're looking for a needle in a haystack, start in the right haystack. So you want to really test somebody with the diagnosis. And then if you find a gene mutation, it can become very targeted for all the other family members once the mutation is known. So instead of looking through entire books, they just need to go to that page, look at that paragraph and in that word and find that typo or it's not there. Luckily, costs are coming down overall, and a lot of these genetic tests are even affordable to test out of pocket. The test results themselves can be complex, being benign variants, harmful variants, or somewhere in between. And since it doesn't really benefit the patient that much, that's why genetic testing isn't routine for IPF or familial pulmonary fibrosis. However, I always advocate that genetic counseling is highly recommended anytime genetic testing is occurring. One of the take-homes I do want to make sure I underscore is whether it's a patient testing for the first time in the family and they're negative, it's really uninformative. You kind of rule out the current genes that we can test for, but it doesn't rule out an inherited cause or a genetic cause for the fibrosis in the family. And this could be for many reasons. You know, maybe we didn't test the right genes, or the gene in the family hasn't been discovered yet. Or maybe the technology we have, which is cutting edge at this point, still didn't find the mutation that's buried way down in the gene where we don't think it's important enough to look yet. Only through research can we improve our knowledge of the genes, as well as our technology can improve our ability to look at them. There's always a chance that there's a non-genetic component to the fibrosis in the family. Perhaps they had a similar exposure or work in a field that happens to have a higher increased risk for pulmonary fibrosis. At any rate, a negative result, unless you know there's a gene mutation in the family, is uninformative, and unaffected family members can rely on their family history to dictate any screening or management. And you could also consider testing other affected family members, but the likelihood of finding a mutation in one and not the other is pretty low since it's a rare disease. So for risk and benefits of genetic testing, I think the top one is learning genetic status. Some people really want to know if they carry a mutation, others do not. They just don't want to know. So this takes that toll on the emotion and psychological, or that psychosocial piece, but it can also be very empowering to confirm their risk or know that they're not at risk. I do talk a little bit about genetic discrimination. So my next couple of slides are on that. But if you look at it from a benefit standpoint, some people can form a prevention plan, especially as we learn more about ways to prevent pulmonary fibrosis or treat it. Those who might be positive mutation carriers might screen early, and if they ever see early markings of interstitial lung disease, they may be able to talk to their doctor about getting on some of the current drugs that slow the progression. So for genetic discrimination, historically it was fear-based. There weren't that many cases of people actually being discriminated against by health insurers for genetic testing. However, it really drove this federal law to come into play in 2008. Other states, I mean, most states had a law, but they were very inconsistent because each state made their own law. The Genetic Information Non-Discrimination Act, which is called GINA, is separate from, say, the Affordable Care Act. It's its own federal law, and it only applies to health insurance and employment. So basically what it does, though, is it prevents a health insurer from using a genetic test result to deny coverage, raise rates, or determine if they're eligible to be covered. A genetic test result can't be used as a pre-existing, it's not really a pre-existing condition, it's more of a predisposition. The Affordable Care Act takes care of pre-existing conditions. And it also prohibits health insurers from forcing an individual to do genetic testing. For employment, this law prohibits genetic test results from being used in hiring decisions, firing decisions, promotions, or being forced to do genetic testing by their employer. But it's also important to know what it doesn't do. It doesn't cover elective insurances like life insurance or disability. So a lot of times people who will find out there's a gene mutation in their family. Before they get tested for it, they will go out and get their life insurance taken care of or any disability in place so that a life insurer couldn't use that against them. However, it doesn't mandate that your health insurance cover for any screenings or treatments either. It usually doesn't apply to the military, federal employees, or the Indian Health Service, mainly because they've had their own laws in place for some time. And one other take home is it doesn't protect the manifestation of a disease. So if you already have the diagnosis, whether it's genetic or not, if the Affordable Care Act, that law for pre-existing conditions ever goes away, a health insurer could still use that against you. So about 2 years ago, I think we concluded on a Pulmonary Fibrosis Foundation's position statement on genetic testing. We made one for clinicians as well as for patients and caregivers. And it really just gives an overview of FPF, kind of like I did today, genes and variants, but the guidance. So really, if I were seeing a patient in clinic, these are the guidance I would give them. First of all, I would always test somebody with the diagnosis or likely genetic forms, like a sporadic case who has, some of those other features or syndromic features of another inherited form of pulmonary fibrosis. Ideally, they would be seen by a pulmonologist or a geneticist or genetic counselor who's well-versed in the genes for pulmonary fibrosis. Genetic counseling is strongly recommended for all those risks and benefits that we talked about earlier. A negative result, again, is uninformative unless there's a known mutation, and we know that there's more genes to discover. So there are limitations to genetic testing right now. We know it's multiple genes, we know there's more genes to find, and we know the testing can't always detect the mutation in the family. We do not recommend testing in patients who don't have an active diagnosis of pulmonary fibrosis or minors. In unaffected family members, only if there's a known mutation. Otherwise, those folks can consider baseline screening in the clinic. As far as minors, it's just general. It's a general blanket statement in the genetics world that if it doesn't affect you as a minor, there's no need to test you because there's nothing we can do but give anxiety and worry to that minor. So we wait until they're an adult and they can make an informed choice to be tested. And as far as baseline screening, there's really no established guidelines. I think we're going to have some soon with our research through Vanderbilt University. If there's a known mutation in the family, genetic testing can be done, and then they can identify the people who are carriers, and then they can follow the next bullet point. Whether there's a mutation known or not, baseline screening has been recommended through pulmonary function test, high resolution CT scan, a standard questionnaire on shortness of breath or dyspnea, usually at 40 or 50 or maybe 10 years younger than the earliest diagnosis of pulmonary fibrosis. The research being done at Vanderbilt on early IPF, where they're trying to determine when the diagnosis actually starts, they published in 2015 that about 14% of unaffected relatives who had familial pulmonary fibrosis in their family already had early signs of scarring on a CT. Now, whether they would ever go on to develop it, we're not sure, and we're following them. And 35% actually had an abnormal transbronchial biopsy. Family members could also minimize their risk. Smoking has been shown to be an independent risk factor for the development of pulmonary fibrosis. So I always say if there's one more reason not to smoke, there you go. Maintaining a healthy BMI and lifestyle, just in case if you ever were to develop pulmonary fibrosis, and lung transplant is still on the table as a cure, and just to avoid known triggers for pulmonary fibrosis. Here are some of the resources for patients and their families as far as accessing information about familial pulmonary fibrosis, genetics, and also how to find genetic counselors. The telehealth options are great for people who are pretty remote. I worked at one place. I know that they have a lot of information, so that might be a good place to start. The Informed DNA, just because I don't work there anymore, so I don't have any benefit of that, but I know that they were well trained by myself in that area. And of course, looking at clinical trials and even DNA banking, if you're not ready to do genetic testing or genetic testing did not yield any positive finding. Clinical trials are always helpful in advancing the field and knowledge of genetics and pulmonary fibrosis. I know there are several out there, but the two that I know the most about occur out at in Denver at the University of Colorado, as well as at Vanderbilt University. So in summary, we know that there's a familial and hereditary component that exists in IPF. We know that up to 20% of IPF does run in families, and out of that 20%, we can find a gene mutation in about 25% of the families. The majority of families show a dominant inheritance pattern with reduced penetrance. We know there's not a single gene like in other conditions, like cystic fibrosis is a single gene disorder, but we already know that pulmonary fibrosis has multiple genes identified, and it may even depend on the family which gene that is. We know that there's both rare variants as well as common variants, as well as environmental factors at play on the disease manifestation. We do think there's an increased risk to unaffected relatives in familial pulmonary fibrosis. So by default, they have a higher risk than say somebody with sporadic or no pulmonary fibrosis in their family. But again, it doesn't mean that they will develop it. And all of this leads to the fact that patients and families with FPF do need that recognition, support, and resources. And hopefully they'll utilize genetic counseling in understanding these issues.
Thank you, everyone, for staying through this session. We have with us Janet Talbert for the Q&A portion. Now, we have a number of questions that have come through our chat here. The first question, Ms. Talbert, is genetic testing done with blood work?
Yes, traditionally it was done with blood work. However, there's new modalities such as a cheek swab or spit kits. The only exception would be if someone had a bone marrow transplant, then we would need another form like a skin tissue.
Okay. The next question, what is the difference between hereditary and familial fibrosis?
So familial gives a nod that a disease is running in a family like IPF, but the gene isn't known. Hereditary is when there is a gene known in that family and you can identify it.
All right, thank you. So our next question is familial IPF usually expressed at younger ages than non-familial IPF?
Not always. So there's one set of genes, camp of genes that we do see in, say, pediatrics, childhood onset, infancy, young adult. So whenever we see that in a family, we do think about those genes. But otherwise, the majority of FPF is anywhere from 40s, 50s, 60s on up to 80s. I've seen it in families. There is a question on whether it can exhibit anticipation, what we call that in genetics, where it gets younger and younger, but it could be that people are more aware and they're getting screened earlier and detecting it.
Okay, so we received a follow-up question to that. Is it true if you are diagnosed in your 70s, it is probably not familial IPF?
Not necessarily, as long as there's 2 or more individuals in the family, no matter what age, that they have pulmonary fibrosis, we still call that familial. And I have seen families where everybody got it in their 80s.
Okay. So the next question here is there a relationship to cystic fibrosis?
None that we know of so far. We know that the diseases are different. They're just have that fibrosis name in there. There are different genes. Cystic fibrosis is a single gene disorder. One gene causes cystic fibrosis. And we've found so far multiple genes for familial, and they're not the same gene as cystic fibrosis.
Okay. So our next question is, what is the difference between familial and idiopathic pulmonary fibrosis? And the questioner goes on to provide a little bit more detail with respect to having an identical twin brother who was diagnosed with IPF in 2015. He was diagnosed in 2017, but their clinical courses have been different.
Right. So two members, so even identical twins, having idiopathic pulmonary fibrosis, we would call that familial still. And, you know, twin studies have always been done in genetic studies because identical twins having the same genome pretty much from the start can give you information. But I do know so we would still consider that familial even in identical twins. However, we've known for some time that, you know, for pulmonary fibrosis, the disease course isn't the exact same for everyone. So even though their disease courses are different, it doesn't negate that familial basis.
Okay. Okay, so where can someone get genetic testing in their local area?
The best place to start would be going to those resources like nsgc.org and find a genetic counselor. Maybe checking with the Pulmonary Fibrosis Care Center in their area as well. Finding a medical geneticist, a university hospital. I think cancer genetic counselors, where there's more of them, and since there's so much overlap with the type of genetic testing and the same laboratories being used, hereditary cancer companies might be a good alternative. And then there's telehealth as well. Companies that do telehealth genetic counseling that can facilitate genetic testing.
Okay. So next we have, how do you decide what genes to test for? Or do you have a usual group you test for? You mentioned, well, that's the first question. Then there's a follow-up question. But how do you decide what genes to test for? Or do you have a usual group to test?
Kind of both. Like if it's really strongly like young age of onset, we might start with those genes that we can see in the pediatric forms first. Or we might test for all the known genes currently, since it's simple to do through laboratories with one DNA sample. So it really depends on what's available and what their insurance may or may not cover and how much the cost ends up being on the approach. But definitely there's lots of options, which sometimes makes it more complicated, but also gives a little more power to the patient as well.
Okay. So in your research and your experience, have you come across many people who have used genetic testing for IPF to assist in reproductive decisions?
Not used a genetic test, but just the idea that something is in their family. They have used the knowledge, which that's where genetic testing would actually help, because if we can find a gene mutation in the family and that we know they don't carry it, we know they can't pass it down. The other thing I like to talk to people about when they're making those reproductive decisions is, you know, by the time a baby comes into the world and is 70 years later, you know, hopefully we're going to make a lot more strides by the time that child would be the age that they would develop pulmonary fibrosis. And with reduced penetrance, we can't predict that they will develop it at all as well.
Okay. Is there any value of genetic testing to inform physicians in treatment options for patients? For example, MUC5B and Talbert SNPs and reactions to NAC and acetylcholine?
There is that study right now, the Precisions trial, that's looking at Talbert and NAC and seeing if there are people who are, better tolerated or shouldn't take it. The thing about SNPs or SNPs, that stands for single nucleotide polymorphisms, is that, we can make those relationships and we can use those as targets for therapeutics. So that's the goal in those SNPs. And right now we're still trying to learn what these SNPs do and how they're behaving and causing the disease or playing a role in the disease. For instance, MUC5B, while it's significantly associated with IPF, it's also has a protective effect if you have that SNP as well.
Okay. So we have a lot of questions still coming through. You mentioned that familial IPF is about 20% of occurrences. Is that statistic based on a large sample size?
I think it's based on multiple papers that have been published. It used to be thought that familial was only about 2%, but other studies coming in with large N's have shown that up to 20% of patients do report a positive family history.
Okay. Okay. Are the genes that are known to cause pulmonary fibrosis associated with other diseases?
Yes. So one camp of genes is associated with other rare inherited syndromes like dyskeratosis congenita, which is a premature aging syndrome. It has about 11 different genes, and I would say maybe about, I'm just going to take a guess here without looking at the list, but maybe 7 have overlap with pulmonary fibrosis without the other clinical manifestations of that rare syndrome. There are rare syndromes like Hermansky-Pudlak syndrome that also have fibrosis that occurs in them. So there are those genes too. The more syndromic a disease is in a family or in a patient, we tend to think about it as that rare inherited syndrome, where familial pulmonary fibrosis with no other clinical manifestations might just be part of that spectrum of that gene. And there's still so much to learn about that. So, but yes, they can have other clinical manifestations. It just depends on the degree.
Okay. So do you only look at 3 generations in genetics and familial pulmonary fibrosis? This individual says in doing their research, they found IPF in the 4th generation.
We go out as far as we can, but at a minimum, we do 3 generations. The further out you go, the less genes you share with those relatives. So the likelihood of them having a common cause for the familial may be just by chance that they have IPF for some other reason. So you want to be careful. What you want to see is closer relatives tying those relatives together to a 4th generation.
Okay. So we received a lot of questions about, funding and coverage, insurance coverage. So there are 2 in essence, are you aware of any Medicare coverage guidelines for genetic testing? That's the first question.
Okay, so for Medicare is tough. Genetic testing, they want to see that it's going to have that clinical utility and be used to treat the patient or have some kind of outcome, not just so they know for other family members. So sometimes Medicare, even in cancer, won't pay for genetic testing unless it's going to do something for the patient. However, a lot of laboratories recognize this, but recognize that the patients still need to be tested, and they often have a low out-of-pocket cost for Medicare patients, and some of them even offer free testing for Medicare patients. Depends on the lab.
Okay, and we received this a number of times. What is the average cost? What is the ballpark of genetic testing? And I'm sure that varies.
It can. So I would think for large panels with even genes that you don't need for pulmonary fibrosis, like the cystic fibrosis gene, sometimes they can range up to $3,500. But some laboratories offer full panels of the known genes for pulmonary fibrosis for $250 or $350. And when you find a mutation in a family, a lot of times a lab will only charge about anywhere from $50 to $200 for another family member to be tested. So the cost does vary between the labs, and that's why it's important to get the right test for the right patient.
Okay. So how do you differentiate familial pulmonary fibrosis between brothers? So this example is from two brothers, one working in a coal mine or siblings working near a farm silo. So it's really about siblings and familial pulmonary fibrosis.
Again, right now, based on what we know, two or more family members would be considered familial. Overall, IPF is not considered a common disease right now. That could change in the future as diagnostics gets better. But generally, a rare disease being in two or more individuals, you tend to think more of a genetic or hereditary component than an environmental. We see this in cancer a lot, but cancer is very common. 1 in 2 people will get cancer in their lifetime. So you could have a family with 5 people with breast cancer and 4 of them carry an inherited form, and the other one just got breast cancer because breast cancer is the most common cancer in women worldwide. So we can't exclude that possibility for pulmonary fibrosis. It's just less likely until we know more.
Okay, so I know you mentioned the websites and some other resources, but everyone listening to you today who is interested in genetic counseling, genetic testing, where would they begin? How would they start?
Well, first of all, I always propose that someone with the diagnosis undergo genetic testing. So I always say, if you're looking for a needle in a haystack, start in the right haystack. Mm-hmm. They can have that conversation with their doctor, a pulmonologist. If the pulmonologist isn't familiar with genetic testing, they can be referred to a local genetics clinic to undergo genetic testing and genetic workup evaluation. There are several tools, even for geneticists not familiar with pulmonary fibrosis, to have a quick synopsis in order to know what genes to order. There's publications, there are online resource tools for them as well. So I would say start with your doctor. If your doctor doesn't know, they can refer you either to a local genetics clinic or maybe one of those telehealth companies that can work with the doctor.
Well, thank you so much. We managed to get through most of our questions today. This was very informative. Before you leave today, I'd like to remind you that one of the highlights of the summit is coming up this afternoon. Academic and industry researchers have submitted abstracts of their scientific research for poster presentation. This session starts at 3 p.m. in the poster hall, which you can enter by clicking the link in the menu bar at the top of your screen. The award winners will be announced back here in Theater 2 at 5:15 p.m. Thank you, everyone. Enjoy the rest of the summit.
Thank you.